Meine sehr geehrten Damen und Herren, wenn Sie bitte die Plätze wieder einnehmen würden, dass wir mit dem Programm weitermachen können. Genau, ja. Ja, willkommen zurück zu weiteren 3 hochspannenden Vorträgen. Der nächste Vortragende, wie schon angekündigt, wird auf Englisch vortragen. Ich wurde von der Akademie gebeten, die Einführung auf Deutsch zu machen und habe mit Charlie schon gesprochen. Er ist einverstanden, auch wenn er nicht weiß, ob ich jetzt was Gutes oder Schlechtes über ihn sage. Aber wir kennen uns so gut, dass wir uns gegenseitig sehr vertrauen. Also, Professor Charles Taylor. So first, a few words I have to say in English. I'm sorry, but first of all, thanks a lot that you really made the trip. I mean, nobody was expecting that at the Academy of Science when they said, "Well, he's really thinking about coming to Munich and to give the talk in person." And they, until I think 1 or 2 days ago, they still asked, "Is he really coming? I mean, is he in person here?" So everyone was prepared for having this talk as a live stream. But so we are all very pleased that you are here. Thanks a lot. Vielleicht ganz kurz, weil er hat so viel Spannendes zu erzählen, ich will die Zeit nicht wegnehmen. Also, Charles Taylor, ich kenne seine Arbeiten schon aus seiner Zeit, wo er noch, also seine Promotionen noch, bevor ich ihn kennengelernt habe. Also die Arbeit, die er damals in seiner Promotion gemacht hat. Er war dann später, er ist auch von Hause aus ein Ingenieurwissenschaftler und Mathematik studiert, war dann eben, ja, Karriere ganz kurz gemacht, war dann auch Professor in Stanford und hat dort würde ich mal sagen, eine der führenden Arbeitsgruppen in der Welt geleitet und aufgebaut. Und aus der Zeit kennen wir uns also schon seit sehr vielen Jahren. Charlie hat dann, irgendwann mal hat er neben der Professur auch ein Unternehmen gegründet und hat dann auch nach einiger Zeit, hat er seine Professur in Stanford aufgegeben und hat sich voll dem Unternehmen gewidmet. Das ist die Firma Hardflow, die er aufgebaut hat und die dann im Wesentlichen also wirklich völlig innovativ abgegangen ist, mittlerweile zugelassen in der ganzen Welt. Und ich sage mal, von den paar hundert Technologien, digitalen, die von der FDA in den USA zugelassen sind, ist das die eine Technologie, die wirklich tatsächlich in großem Stil in Standardkliniken angewendet wird und auch sogar von Medicare, Medicaid gefundet wird. Und nur ein kleiner Hinweis, ich weiß nicht, ob es er drinnen hat, aber gerade vor 2, 3 Wochen, glaube ich, kam ein Artikel raus, also ein wissenschaftlicher Artikel aus England. Also die Technologie wird mittlerweile weltweit eingesetzt und da haben sie also festgestellt, haben das mal untersucht, dass durch die Anwendung dieser Technologie, die computerbasiert, also simulationsbasiert, was ich versucht habe einzuführen im letzten Vortrag, wie viele Menschenleben dadurch gerettet wurden und wie viele zig Millionen Pfund für das National Health System in UK eingespart wurden durch die Anwendung dieses Systems. Seit kurzem hat er dann seine unternehmerische Tätigkeit sozusagen zurückgeschraubt, ist also nicht mehr aktiv in der Firma, natürlich noch im Board und spielt immer noch eine Rolle. Und seit Anfang dieses Jahres hat er jetzt wieder in die Akademie zurückgekehrt, also in die akademische Welt und hat eine Professur angenommen an der UT Austin in Texas, wo ein neues medizinisches Zentrum aufgebaut wird. Die hatten noch keine Uniklinik und die sich also speziell der digitalen Gesundheit widmet und wo Charlie eine tolle Rolle spielt. Vor kurzem wurde er auch in der National Academy of Engineering aufgenommen, also eine große Ehre. Und alle anderen Preise lasse ich jetzt einfach unter den Tisch fallen. And now the floor is yours.
Thank you, Wolfgang. Thank you for the kind invitation. It really is a pleasure to be here. Before I start, I just want to say it's a pleasure to have Professor Achenbach here. You know, his work in cardiac CT imaging has truly impacted the lives, saved the lives of probably tens of millions of patients so far. The exam is done many millions of times per year worldwide. And, you know, anything that I've done certainly wouldn't have been possible, you know, with that, if not for the pioneer work of Professor Achenbach. It's really a pleasure to be here and have an opportunity to share the floor with you, Stefan. So I want to talk about simulation in AI and clinical application. Can you hear me okay if I don't need to stand at the podium? So there's been a lot of talk. I want to talk a little bit about artificial intelligence in medicine as well. And there's been a lot of discussion about the role of artificial intelligence and how that will impact the role of physicians and doctors. And, you know, this person here, actually just won the Nobel Prize in Physics, so probably a lot of people listen to him. But back in 2016, he said that in 5 years, he said we shouldn't train radiologists. In 5 years, radiologists, we won't need them anymore. And this is maybe a reference to an American cartoon, The Roadrunner, where a coyote's chasing the roadrunner, runs off a cliff, and then doesn't realize he's about to fall until he looks down, which is at the time he falls. But this was the idea. This is the pronouncement that was made about what was going to happen to physicians interpreting medical images, radiologists. More recently, Bill Gates said, well, it's not just doctors, it's also teachers, that in 10 years we won't need doctors or teachers anymore. Because it's pretty depressing, isn't it, to say humans won't be needed for hardly anything. Look, he's completely wrong in my estimation. So I thought, what about a real expert? I want to go to a real expert and see what a real expert thinks about this, about whether, you know, in 10 years doctors are going to be replaced by AI. So I went to ChatGPT. And ChatGPT actually was a much more balanced approach. It was so sensible. I was so surprised by this, and maybe this was actually edited by a person. The real answer, of course, from the AI said, of course, we're going to replace doctors, and maybe some person behind it, you know, edited before it was sent back to me. But actually, it was pretty sensible, and you look at the conclusion, yeah, there's a lot of things that AI will be able to do, and I think, indeed, AI will be an incredibly powerful tool in many areas of medicine, but it's not going to replace physicians. Perhaps there will be in some specialties, the work that they do will undoubtedly change. Some tasks, hopefully, some of the more burdensome tasks could be augmented, could be sped up. I think there's an important role. I really like the bottom line here that ChatGPT said, it'll be a powerful assistant, not a substitute for doctors in the next decade. Outcomes will come from human-AI collaboration, not competition. I think maybe we should listen to ChatGPT instead of the previous two individuals. I did ask ChatGPT to give me a quote of Mark Twain as a physician, which was great. He created this nice image for me with the quote of Mark Twain, which I really like. The reports of my death are greatly exaggerated, and I think this is absolutely true about the reports of the death of our professions in medicine and in teaching. I think are greatly exaggerated. But we're going to have to understand and figure out, you know, our changing roles. About 30 years ago, I first presented a computer model, a simulation of blood flow in a patient's aorta and aneurysm that was created for medical imaging. It's the first time that had been done 30 years ago, as I was still a graduate student at Stanford. And I presented this at a conference. And at the conference, there was also a talk, and I told Dr. Achenbach this earlier, there was also a talk about the internet. And the idea was, this is 30 years ago, and the question was, is the internet a big deal, right? So all of the younger people in the room, they just, how could you possibly ask that question? But 30 years ago, people were asking the question, is the internet an important advancement in human history? Is it like fire, or is it gonna be some, you know, smaller advance? And I think the conclusion of the speaker was, indeed, it's like fire. And I think that is 100% true about artificial intelligence. I think it's going to dramatically change our lives, maybe more rapidly than the introduction of the internet and web browsers and searches, et cetera, came about. When I was a graduate student at Stanford, I remember being in the computer lab and seeing a web browser for the first time. It came out of the University of Illinois, Urbana-Champaign. It was called the Mosaic browser. It was actually a Ph.D. project of Mark Andreessen. And he had this web browser. I thought, this is really extraordinary. I could recognize that. But for all of the younger individuals in the room, life was a lot different before we had that. You know, our access to information was very much different. I spent a lot of time when I was doing my doctorate in the library, the basement of the library at the medical school, flipping through journals, reading papers, looking at other references, et cetera. Access to information is completely different, and our ability to synthesize information has really dramatically changed. So I want to talk a little bit about, we'll talk a little bit about artificial intelligence. in many fields, there's this thing called the hype cycle. So obviously we know what hype is, probably fairly universal, well understood in German as well as it. We're masters of hype in America, as our current political situation perhaps might show, hype and hyperbole. But this idea of the Gartner hype cycle is that within early innovation, there's a period of a peak of inflated expectations, followed by a trough of disillusionment. Maybe now some progress is being made. People figure out how to use a new idea, bring it forward, a slope of enlightenment, plateau of productivity. So the AI part of it that I'm going to talk about will be really in computer vision and helping computers to help interpret medical images. And this is something where there's a lot of productivity that's realizable from this. But there's some of the earlier ideas in artificial intelligence are still probably are sometimes overhyped. So there are a lot of AI products that are being used in healthcare. In the United States, the US Food and Drug Administration has cleared 1,000 AI products. 1,000. It's an extraordinary number. You actually see in radiology, there's a dominant number is in radiology, followed by cardiology and other disciplines. So there are a lot of AI technologies available and that are even cleared, have gone through the regulatory process. The challenge, though, is that they're not really fully integrated into healthcare yet. And because it's hard to integrate products into healthcare until you integrate them into the healthcare payment system. Until you can go to a doctor, physician can order a test, your insurance pays for it, the test is available, more widely available. So if you look down at the tests where AI is used, by the time after you've gotten through the first 10, now this is a couple of years old, but after you got through the first 10 technologies that are cleared, you're talking about single digits in terms of the reimbursements, single digits of patients where this has been covered. So most technologies that have been created are not really integrated into healthcare. So that's one of the challenges. I'm going to tell you about the technology that I developed. I actually started working on this 30 years ago, some of the core technology. It wasn't until after that, in around 2010 or so, 2008, 2010, where I conceived of this idea of actually using a coronary CT angiogram to extract information about the coronary arteries to simulate blood flow. And again, it was because of the pioneer work of Professor Achenbach that made this possible. But in 2010, we could start to think about using this type of technology, extracting information from medical images to help improve the diagnosis of heart disease. And I started the company HeartFlow with my colleague at Stanford, our former chief of vascular surgery. So both of us were Stanford professors. We spun the technology out of the university, and most of the technology was developed in my lab at Stanford. So the problem, and fortunately Professor Achenbach talked about the problem of heart disease, about when we have heart disease, the atherosclerosis in the coronary arteries, and if the disease progresses, the possibility of plaque rupture causing heart attack. So it's coronary disease is one of the primary heart diseases. And also as Professor Achenbach spoke about, there are invasive tools to be able to look at, understand a patient, to do an invasive, an X-ray image or an angiogram to understand whether there's disease in the coronary arteries. And now increasingly, physiology tests are being done typically by putting a pressure wire, a wire down into the coronary arteries during cardiac catheterization to measure changes in pressure through the coronary circulation, and that information is really useful for making clinical decisions about whether a patient would benefit from a stent or maybe they could be managed with medicine. For example, medical management. So the challenge is that you require cardiac catheterization for these procedures, and only about 40% of patients that enter the cardiac cath lab with traditional non-invasive testing strategies have areas of narrowing in the coronary arteries that would even give you an indication for measuring pressure, for putting a physiology measurement, and only about 40% of them have a positive physiology test. So the idea is that certainly less than 20% of patients that with traditional non-invasive testing that would enter cardiac catheterization lab would have both anatomic evidence disease, a physiology compromise, a limitation of blood flow to the muscle of the heart that would be a clear indication for an interventional treatment, a stenting procedure like Professor Achenbach spoke about. So the question is, could we do this before cardiac catheterization? Can we identify, do a non-invasive physiology test together with the anatomic assessment and do that before the patient is in the cardiac catheterization lab and try to find, the majority of patients that might have significant heart disease to identify them with non-invasive testing strategy. And again, thanks to Professor Achenbach, the anatomy it's remarkable. And the latest images that he showed, for instance, of the coronary arteries, it's just astounding how good the quality of the data is. What insight we have. I think probably I heard a few gasps when he showed. I think you must have showed one of the first images of coronary arteries, and then a more recent one. It's remarkable what we can see with this technology, this imaging source. And what I focused really the last 15 years on is how do we get physiology? How do we actually use the anatomy from CT, use computer models, AI, to actually simulate blood flow from a coronary CT scan and predict benefits and help provide this information to cardiologists to guide treatment of patients. And this just shows the technology and available in a computer browser, app on a mobile phone, or reports that could be put into medical records. And that's the technology, this non-invasive physiology information. So essentially, when you look at a report like this, if it's red, or yellow, orange, red, it means that there's a compromised flow to the muscle of the heart. If it's blue, it means that there's the flow is not being compromised through that vessel, through that coronary artery. So how do we do it? Where's the AI part of the story? When I describe what this technology, how we built this, there's anatomy, there's physiology, and there's physics. And the physics is basically, people talk about computational fluid dynamics. It is kind of rocket science. It is one of the sciences, at least, that's used to design rockets. But it's computer models and simulations of flow, not flow on a rocket or a flow over an airplane, but blood flow in our cardiovascular system. I'll tell you a little bit about that. So the hard part of the problem where AI comes in is the interpretation. So these are images not obtained at Professor Achenbach's center. These are what you would often see when you do medical imaging around the world. And, quite frankly, not everybody in the world has the newest, most modern scanners. And sometimes it's difficult to be able to interpret the images from a coronary CT scan. So AI is absolutely very valuable. It's in this part of AI which is called computer vision. If you come into the city of Austin or San Francisco, by the way, you will see this vehicle. This is actually a company, autonomous autonomous cars. The company's called Waymo. They're everywhere, through this city. It's a little bit surreal when you're driving along and you look in the car next to you and there's no person in the car at all. Or there's a person in the back seat. But this is absolutely, you can order it in your Uber app, actually, in the city of Austin or in the city of San Francisco. And increasingly, you're seeing this. It actually is surprising, even to me, who works in the field, how far this technology has come along. And how did this work? Well, it was a bunch of people sitting inside of cars with all this sensor equipment on the top, driving automobiles and teaching a computer how to drive. And it is remarkable that you can do this. It works. You can teach a computer how to drive. And I would venture a guess that it's probably safer than a lot of situations where people are behind the wheel, quite frankly. But our expectations, by the way, is that they never crash, right? That we have a very low tolerance when it's a machine doing it. We might not accept a very low fatality rate that with human drivers we just it happens all the time. But it's remarkable how far this has come along. And so here's a challenge of actually interpretation. This is an actual patient that was sent to HeartFlow with a lot of coronary calcium. White is the coronary calcium. This is not that old of a CT scanner, not the newest one, but not that old. And this is a patient with a lot of coronary disease. And how would you actually interpret that? So what is the story behind this? How does it work? Well, you're not going to be able to interpret an image like this. And I would venture a guess that a physician that's learning to read a coronary CT, interpret it, they have to ultimately they have to know what the answer is, at least for some set of patients, a ground truth. So for a physician interpreting CT, to see an X-ray image, an angiogram of a patient when a patient like this could help them learn how to interpret the images. So that's the first thing you can do. If you want to teach a computer to do that, well, if you have patients where you have ground truth data, it's really helpful. So this is how we started. We had patients that went from a CT scan that went into intravascular imaging, a technique called intravascular ultrasound, to image inside the coronary arteries. We could extract information from the computer algorithm and then test it against the invasive data. This is a better depiction of this. So this shows patient with a coronary CT scan, a lot of calcium, cross-sectional images of the CT. It's very hard to interpret where the boundary of the blood vessel is, but if you use a technique called optical coherence tomography, an invasive probe that is put in the coronary arteries, you can see exactly where the boundary of the blood vessel is, even if there's coronary calcium in those situations. And then you can overlay the CT in the invasive imaging, and you can actually essentially teach a computer to interpret the boundaries with a non-invasive test by using the ground truth, essentially the gold standard. The other part of it, which I have to say was a bit of a serendipitous realization, was that because we built a system where all the image data would be sent to a central location for data processing and data analysis, and we would interpret the results and send a report back, the interpretation of the images back, we were able to have all of the data coming in, and we build in automated algorithms where we have automated algorithms extracting the large structures, tracing inner boundaries of the vessels, or the center line of the vessel and the boundaries of the vessel. Automated algorithms followed by a human inspection correction process. So this is akin to people driving, teaching a computer how to drive, but what they're doing is they're actually correcting the results of the automated algorithm in the context of the image data, and that's what was necessary to get a high-quality report for an individual patient. But the corrected data could be fed back into future generations of the algorithms. And when I saw when we started to have thousands of patients of corrected data sets, curated data sets, tens of thousands, then the algorithms, the AI algorithms started to get really good. And it's not just having a lot of data. I would say a mistake to think that you can just put a lot of data into a computer and it's going to figure all this stuff out. But if you take high quality, curated, annotated data where a human has tried to refine, improve that information, then you can actually get to the point where a computer can do things that is you would never expect it to be able to do. The third part of it is that when we would provide a result back to a physician, if the physician would go to the cardiac catheterization lab and see a different result in the cath lab versus what we predicted, I would visit our customers. I would say, if you see a difference, complain. Please complain about our product. Most people would say, well, why would you have that? But in fact, that's feedback, right? So we would get feedback for patients. For instance, this is a case where it was different between what we extracted versus what was observed in the angiogram. And you could use this information to correct, essentially learn from your mistake so that you could not make the same mistake, as often in the future. And what we were able to do is track over time. Now, I'm going to say at the outset, these are customer-reported false negative, false positive rates. There's no test on the planet that is that good. Both are obviously underreported. But if you look at the trend over time, over years, you can start to reduce the errors, so to speak, in the test with feedback, and by doing root cause analysis and investigating what went wrong in the past. Okay, this is a fraction of a percent, and even to this day, it's traced out. It's monitored consistently over time. And anytime a customer says you got a different answer versus what I predicted, that there's an investigation, a root cause investigation to try to figure out why and try to prevent that from happening in the future. And then this was the interpretation of this case. This is a patient actually who went from CT right to cardiac surgery, was operated on based upon the non-invasive data. So that's the anatomy. The physiology is really the whole secret to it was turns out our blood vessels kind of know how big they're supposed to be. Every blood vessel of our body has endothelial cells that line it. So when we have a territory of the part of the muscle of the heart that needs more blood, the vessels that are feeding it get bigger, they adapt, and they enlarge. So we can look at the signature of a network of blood vessels and actually figure out roughly how the blood is distributed to the muscle of the heart. And take a static image of CT and actually predict the physiology function. And then the last part of it is the physics. There's a lot of math here, but this is just for those of you, high school physics, Newton's second law. It's not even high school physics, right? You probably learn in middle school, but F equals ma. But it's F equals ma generalized to a fluid. This is literally a conservation of mass. This is a generalization of Newton's second law to a fluid. We couldn't solve that without a digital computer, but now it's obviously pretty straightforward. So that's the story behind the test. It's regulated as a medical device. It's considered as a medical device in Europe, in the US, and Asia. And it's been very, very well studied, a lot of publications. I don't know why it's a little strange on the screen. Let's see. Okay. Try that again. Okay, that's better. A lot of publications, a lot of clinical data, a lot of clinical studies that have been done. Many of these investigator-initiated studies. And you know, one of the first questions is, does it work? Does it work as an alternative to invasive pressure wire? This is a paper that was published in Journal American College of Cardiology, a fourth accuracy trial comparing this test to other non-invasive alternatives. This was a study that was done more recently. It was done in Europe, and it was looking at patients that had disease in their legs that are typically not evaluated, where the coronary arteries are not evaluated. And this is a study that showed if you used the technology CT and you did physiology testing, you could actually improve survival in a patient population out to 5 years. So that's important, obviously. In the UK, we went early through a process, the National Institute of Care Excellence in the UK, to evaluate the test. In 2016, the UK changed their guidelines where they said we're going to do a CT first, the CT angiogram first as a frontline test, and if we find disease, to do a non-invasive functional test afterwards. And actually in 2021, the HeartFlow was one of the first products that was actually mandated by the National Health Services, where any National Health Service hospital in England is required to offer this to patients. And this was, I say, these are two matters of the heart. This is about Bill Gates and his divorce, and this is the HeartFlow study, the 20 minutes, anyways, on the front page of London Times. So now there are 4 products that are mandated by the National Health Services in England, and you see them here. Because of that introduction into an entire healthcare system, a couple of weeks ago there was a study that came out in Nature Medicine talking about what happened after it was implemented into the health services, and basically demonstrated that you could evaluate coronary disease, you know, to a greater extent with a non-invasive testing strategy versus invasive angiograms. And in this paper in New England Journal of Medicine, it was identified as one of the most widely adopted AI products based upon Medicare reimbursements. In 2021 was the first AI technology to be included in the American College of Cardiology practice guidelines. So for after CT was now become the level, it's the highest standard of evidence, what's called the level 1A test. In the United States, and then after you do a CT, again, preferentially, you could do functional testing if you found a coronary disease there. Now it's possible to do many other things besides physiology with CT, to get information about anatomy, to get information about atherosclerosis. And for example, quantification of atherosclerosis is now being paid for in the US. AI quantitative coronary plaque analysis is being covered by Medicare, at least in the United States. It's become possible to do that, and you can start to get a lot of information about the coronary arteries before, and this is a patient that had significant coronary disease, and to evaluate the coronary disease using these different viewpoints. The last part of it is if you have areas of disease, and this is an application that runs on an iPhone, you can identify areas of disease, remove a lesion, and essentially simulate what would happen if you placed a stent in that location, or what would be the improvement in physiology. That was validated against invasive pressure measurements, so the prediction of what would happen after a stenting procedure in the coronary arteries. And there's a randomized control trial that now is almost fully enrolled, a randomized trial comparing a CT-guided PCI strategy, CT-guided stenting strategy versus a conventional strategy. So I'll just close here. These techniques have now gone, these models have gone from a lab, from an academic lab into the clinic. It's in clinical practice guidelines. There's a clinical utility for using these tests, and also for predicting the outcome or potential benefit of treatment strategies. And HeartFlow is an example of what you would call an AI-enabled medical digital twin. Wolfgang, Dr. Wall talked about this idea of the medical digital twin, so I won't go through it. I will tell you that it wasn't easy. You know, when you start out, when I left Stanford 2010, 2011, you have no idea what it's going to take when you start to try to create something or bring something into clinical practice and build a company. And I will tell you, my experience was that it's not smooth, it's not easy. There's a lot of challenges of going through regulatory clearance. Once you have regulatory clearance, it doesn't come with a check. You have to navigate complex healthcare payment systems, prior authorization barriers, habit guidelines. The pandemic, really made significant challenges for the testing of stable coronary disease. But I think in the end, you have an opportunity to benefit patients, and this is one of the patients that HeartFlow has benefited. And so far, about 500,000 patients or so that have received this technology. And one of the reasons why I went back after, I would say, a 13, 14-year sabbatical from academia back into an academic role was what we're working on at the University of Texas, is to try to think about a healthcare system and hospitals, how this is going to change. A hospital where we're thinking about artificial intelligence and digital twins and robotics as we build a brand new hospital and as we plan that. The city of Austin is the 10th largest city in the United States, does not have an academic medical center, and that's what actually attracted me back into an academic environment. So thank you very much for your time.
Yeah, Charlie, thanks a lot. It's always exciting. I mean, I heard you many times talking, but it's exciting every time. So, Fragen an Professor Taylor, gerne auf Englisch oder auf Deutsch, wie Sie wollen. Bitte, da haben wir eine Frage. Gleich da, dann kommt da hinten.
First of all, thank you for the presentation. Second off, I was curious what kind of artificial intelligence is being used in the HeartFlow technology.
Yeah, so it's really a computer vision and deep learning methods, the convolutional neural networks that are being used. So we started off with more traditional machine learning techniques. We started to implement deep learning techniques about 8 or 10 years ago or so, but that's what's being used. We're not yet using techniques like large language models. There are opportunities to try to take the information extracted from an image to now think about how do you help make decisions based upon this information, but that's not happening at present.
Und dann haben wir da hinten eine Frage.
Are there already plans to incorporate it in the German healthcare system, or is it already kind of incorporated?
Well, it's plans for in the German healthcare system.
There are certainly attempts. I think maybe Professor Achenbach could correct me, but I think it's been almost only fairly recently that I think coronary CT has been paid for in the German healthcare system, which is surprising because it came out of Germany. But it's CT angiography is now covered, is now paid for, to my understanding, but HeartFlow is not, it is available. There are sites that are using it in Germany, but it's not systematically integrated into the healthcare payment system yet.
It has been used in some patient studies, I know, for example, in some university hospitals, but unfortunately not regularly. Yeah. Innovation again. Professor Achenbach. So here, one question.
I mean, this was a wonderful lecture, Charlie. Thanks once again. And I think you mentioned it in your last answer a little bit. The ultimate information that we would like to get, whether it's AI or in any other way, is, let's say this has been done in 400,000 patients, and there are 200 patients with exactly the same situation, and in these patients, placing a stent helped. So this will be beneficial for you. This would be the feedback loop that you indicate a little bit with the large language models, where we would really help the physicians create a decision based on the result of the scan. Any plans to go in that direction, or is it just too difficult and too huge a task to ever do?
Well, I think the first question, and maybe you touched on this, Stefan, is that to take all the information together. First of all, to take a patient who has a cardiac CT, the first question is, what is their risk? If you have coronary disease, maybe it's flow limiting. What is their actual risk of having a myocardial infarction? And then based upon that, how could you manage the patient? Last year we published a study, the Emerald-2 study in JACC Imaging, and we looked at trying to combine all of the possible information you could squeeze out a CT scan, all the different tests, and put it together and say, could you identify lesions that would be more likely to rupture, causal of a myocardial infarction or not? I think that's the first step. If we could identify patients that, and I think that you've seen these patients, right? There are patients that have a particular pattern of coronary disease, maybe proximal disease and large, bulky, or lipid-rich plaque in the coronary arteries, that it's likely that these patients are at very elevated risk, and perhaps they need to be managed aggressively with coronary stenting. And then likely there are other patients that have coronary disease, extensive coronary disease, but have lower risk phenotype, and they could be managed with medicine. So I think that will be the goal, to try to predict, better identify risk, and then follow that up once with collecting the other information for the patients. I think in the U.S. healthcare system, it's not easy to kind of integrate all of the outcomes data together with all the other information in the U.S. healthcare system. In England, they do a really good job, for instance, of collecting large amounts of data in the population that is served. But I think that would be the goal, ultimately, is to combine that information.
Yeah, thank you very much. I guess in the interest of time, we have to stop here, but Charlie will be also available after the last talk, right, for a couple of questions. Yes. He has yesterday given a lecture to a couple of students, and they kept him, I think, for 1.5 hours with questions, right? So thank you very much again, Charlie.